My lady, are you able to see and hear the hearing room?
I can, thank you, Ms Niels.
My lady, I'd like to call, please, Anna-Louise Marsh.
If you could just repeat after me. I do solemnly, sincerely and truly.
I do solemnly, sincerely and truly
Declare and affirm.
declare and affirm
That the evidence I shall give.
that the evidence I shall give
Shall be the truth, the whole truth and nothing but the truth.
shall be the truth, the whole truth and nothing but the truth.
Miss Marsh, can I just say how sorry I am that I can't be there today? I think you know me well enough by now that I would have been there if I could. But I'm obviously very appreciative of you and your fellow bereaved coming along to give evidence again.
Thank you, and I hope you're on the mends quickly.
Thank you.
Can you give your full name, please?
It's Anna-Louise Marsh.
Miss Marsh, you've provided a witness statement for this module of the inquiry dated the 10th of November 2024. That's INQ 000343992. Can I check that you have a copy of that witness statement in front of you?
I do.
And I think you're familiar with that witness statement.
I am.
Thank you. You're a founding member and co-leader of the COVID Bereaved Families for Justice Cymru, is that right?
That's correct.
And I think that organisation is a non-political, not-for-profit organisation, is that correct?
That's correct.
Could you tell us, please, how the group came to be established?
It came to be established, my father died of hospital-acquired COVID in October 2020, and I immediately tried to get some answers as to how that had happened. I then found other people in the same hospital and the same health board that had experienced similar. And then that grew and found sort of many people across Wales that had experienced the same. And we were part of a UK group, UK-wide group, but we quickly realised that because healthcare and social care had evolved to Wales, that we needed to focus on the Welsh issue specifically.
And can you tell me how many members the group has currently?
We have about 400 members.
And how do members join the group?
They can join via Facebook, they can join via Twitter, they can contact the group directly or go via our legal team.
And could you please explain the purpose and the primary aims of your group?
As I said, initially we wanted answers, which we couldn't get via the sort of formal complaints process. So our initial objective was to call for a Wales-specific inquiry. We felt that would be the right way to scrutinise the very specific problems in Wales. And that's not to say we didn't want to be in a UK inquiry too. We just felt that that would be able to cover the breadth and depth of the very specific issues in Wales.
Thank you. You've helpfully set out in your witness statement at paragraph 56 the extent of the COVID Bereaved Family for Justice Cymru's engagement with a number of organisations, the Welsh Government primarily, but also to some extent the UK Government, the Welsh NHS bodies and other interest groups and independent bodies in Wales. But I think it's right to say that the group had a number of meetings with the Welsh Government during the relevant period and subsequently, and those were meetings with the First Minister, the Minister for Health and Social Services and the Deputy Chief Medical Officer, Dr. Chris Jones. Is that correct?
That's correct, yes.
For the remainder of your evidence, I'd like, if I may, to look at the key areas of concern to your group that fall within the scope of Module 3. So first of all, primary care and access to primary care in particular, I think was a concern for a number of your members, and I think you set this out at paragraphs 16 to 17 of your witness statement. But is it right to say that there was certainly at least a perception for many of your members that general practice was closed or certainly closed for inpatient, in-person visits? Is that
Absolutely,
correct?
Yes. More than the perception, many of our members, including my family, could not access their GP. There was never any any question that there would be a face-to-face consultation. Video consultations never mentioned.
I think you explained in your witness statement that when your father was discharged from hospital, he'd been admitted to hospital for a non-COVID complaint, I think that's right, but he'd been exposed to COVID-19 when he was on the hospital ward. And after he was discharged and was unwell, your contact was with the out-of-hours GP, is that right?
Initially, it was with his personal GP, so there was a number of calls with him. And then as his condition deteriorated, we had visits from 4 out-of-hours doctors, not one of whom suggested COVID, even though it was written on his discharge summary that he had been exposed to COVID on his ward.
Did the out-of-hours doctors appear to have access to those discharge notes?
We have checked, they did.
Yes. And now if we could move on, please, to issues that have been raised by your members in relation to 999 emergency ambulances and the 111 telephone triage service. I think it's right to say that 111, in fact, wasn't available across all of Wales during the relevant period. Is that right?
Sadly not. 3 of the health boards did not have a 111 service. So this is where the divergence, between England and Wales starts. And it was also chargeable in those 3 health boards. It wasn't.
So the health boards
free.
that offered 111, it was a chargeable phone number.
Yes, it's all very complicated and it's unique to Wales, of course. That the 111 service is run by the Welsh Ambulance Service, but then the triage and sort of callbacks are done by the respective health boards.
I think one of your members had an experience of trying to call 111 and not being able to get through, but there wasn't actually a recorded message at that time explaining that the 111 service wasn't operating in that area. Is that correct?
That's correct, yes. And I think one of the main concerns is the confusing, conflicting information that we did get when we called. And part of the problem was that COVID was only deemed, there was only 3 symptoms that were attributed to COVID. So if you had any of those other symptoms, you were just told it's fine, you just, don't worry, when in fact they were clearly COVID symptoms.
So I think the initial 3 symptoms that were identified on the 111 service were fever or chills, a persistent cough and shortness of breath. So it's anything outside of those 3 symptoms that wasn't recognised as a potential symptom of COVID, is that correct?
That's correct, and I think many older people don't display those 3 cardinal symptoms, and they it is extreme fatigue, it's headaches, it's nausea, it's diarrhea, and some others. We're not suggesting that everybody should have gone to hospital or needed a test with everything, but the lack of acknowledgement that those were COVID symptoms, and this. And it was definitely acknowledged they were by October 2020. It's a real miss.
I think one of your members had one of those experiences where they were calling the 111 service repeatedly and being told that their loved one was fine, there was no need to go to hospital, it wasn't going to be COVID, and eventually I think that patient was admitted to hospital, did have COVID, and sadly died from COVID, is that right?
That's correct, yes.
I think there are also some issues that you've raised from your members with emergency ambulances and calling the 999 number and the excessive waiting times in Wales. What steps did your members have to take when they were told they were going to have to wait for hours for an emergency ambulance?
I mean, most of us were told, don't bother ringing 999, take them yourselves. My sister had to literally bump my dad down the stairs and take him in the car. I mean, the poor man could barely walk.
And was your sister living with your father at that time, so she came from another household in order to try?
I mean, we had no choice at that point. He was so unwell that she had to do that to help him.
You also raise issues in your witness statement in relation to the guidance that was being put out for members of the public, the guidance around the symptoms of COVID, and the fact that many of your members found it confusing and unclear. Is that right?
Yes, I mean it was unclear for many reasons. You know, we have the whole England Wales differences, but you know we have a chief medical officer in Wales that said, you know, there's no need to wear face coverings. You know, we got conflicting and confusing communications about shielding, pretty much across the board, different ways of saying things. And you know, again, the symptoms was a key part of that. You know, the whole sort of, you know, protect the NHS. You know, my family would you know, my dad was absolutely not going to go to hospital unless he absolutely needed to. You know, that wasn't the right thing to do. Sadly, he did have to go, and of course, that was where he got COVID. So.
I think you give the example of your father receiving a shielding letter, or at least a shielding letter being sent to your father, in fact, after he had died in October of 2020. And some of the advice given in that letter, including that COVID tests would only work if the patient was symptomatic. Is that correct?
Yes, and not only so, it actually says in this shielding letter that arrived the day after my father died, that was telling him he didn't need to shield, which seemed completely baffling because obviously he was 85 with comorbidities, but that not only that you should only take a PCR test if you had symptoms, but only with those 3 symptoms, and that it was pointless to do one if you didn't have symptoms, which we know in October 2020 that everyone knew that, you know, you could test positive and be asymptomatic.
I think you've also identified that there was an issue with accessibility of the guidance and advice that was being produced by the Welsh Government, in that it wasn't easily accessible for people who were deaf or visually impaired, or indeed had learning disabilities. And it was the case, was it, that not all Welsh Government broadcasts included a BSL interpreter?
Yeah, absolutely.
What about information about local outbreaks? Was there any information put out by hospitals about whether they had an outbreak of COVID at their hospital and whether to stay away? Was that information easily accessible?
No, and in fact, it was well hidden. It was proactively not broadcast. You know, and I think that's one of the obviously the main one of our main concerns is that clusters and outbreaks were not communicated. You know, I literally had to take screenshots of each health board's COVID pages, and I did them, you know, 2 years ago, and there was just practically nothing about COVID on there. You know, even how to protect what you do, you know, and it seems such a simple way of communicating to people, you know, via a website, you know, what you should do and how you should do it, you know, what visiting hours were, what protections were in place at the time. Just absolutely nothing. It was almost like the pages had been forgotten. Also, no letters sent about things. I mean, my father's GP and the out-of-hours doctors didn't seem to be aware that there'd been a cluster outbreak in my dad's hospital, which was 21 patients, 13 staff. And yet the ward had been closed for 4 days after. So it just seemed, in a small place, that wasn't well known or communicated, or at least communicated to local GPs.
If we can look at some of the examples that your members have given about their concerns about the quality of care that was being provided in hospitals in Wales. I think you refer to a postcode lottery in terms of inconsistency between different hospitals in terms of the sort of care and the kind of procedures that were in place. I think you give the example of a patient who had moved hospitals within a single health board in Wales, is that right?
That's correct.
Experienced quite different care in those 2 different hospitals.
And I know the chair's looking at systemic issues, but there are systemic issues that are pertinent just for Wales, but there is also a lack of systemic issues because each health board does things so differently. And that's, it just seems crazy that, there is not at least a commonality about processes and policies. We understand there needs to be some flex for the local, but there should at least be, some consistency. And this wasn't just across health boards, this was across hospitals within health boards, and also at ward level, different rules, different policies, different interpretation of those policies.
And so you've given the example of a family of a patient who wasn't allowed to visit their loved one when they were dying, but also there wasn't any process or means by which they were offered a video call. Is that correct?
I don't think anyone was. That there was zero patient liaison. I think that's one of the biggest things as well. For a recommendation is the lack of a patient voice for the patient themselves and the liaison with the families. That should, if you can't see your loved one when they're dying, which we do believe you should anyway, but if you can't, there has to be, with all the technology we've got nowadays, it's not beyond the wit of man to have an iPad to be able to communicate with them. But then, of course, we come back to the lack of digitisation. In many hospitals and wards, there was no Wi-Fi. So many issues across that communication piece.
I think some of your members had to say goodbye to their loved ones by text message. Is that correct?
That's right, and they just had to hope that somebody gave them that text message. We have many examples of when their loved ones' items are returned, there's a mobile phone with, hundreds of missed calls. And it's not just that kind of communication as well. It's also the communication with the patient. Many patients were not sort of, technically disabled, but age is, of course, a disability in itself. But, people weren't given hearing aids or glasses. Their world was already quite small and silent, and yet that only added to it. And I think, we really have to think about, that. And one of the things I did want to say that, was we've heard a lot about, and absolutely rightly about, emergency medicine and, what happened in ICUs, all vital to understand. But most of our loved ones in our group were older. They led very silent, quiet deaths. And as Julia Jones from John's campaign said, it's almost death by indifference. Nobody communicated to them. Nobody told them what was happening. They didn't have communication with their loved ones. And I really do think we need to ponder on that element of it. It's those quiet, silent deaths that are the real tragedy, I would say.
And you have set out, I think this is at paragraphs 37 and onwards in your witness statement, your members certainly have felt that at times there appear to be some discriminatory practices within hospitals in terms of access to treatment or escalation of treatment for their loved ones when their loved ones were elderly. And you give the example of having to wait 12 hours before the administering of medication, having to wait for CPAP devices, having to wait for high-flow nasal oxygen. I think your father had to wait some time after his oxygen levels had dropped before he was offered oxygen. Is that correct?
Yes, his oxygen levels dropped dramatically, and they knew they weren't going to ventilate him, and we understood that. But he was they couldn't find the high flow oxygen machine for 40 minutes, and then they told us he was dying. We didn't find out about that until 2 years after. That was not explained to us at the time. When I did arrive, fortunately we were allowed to be with him when he died. I was told, well, he became agitated. Well, now we know he's probably agitated because he hadn't had oxygen for 40 minutes. But I, as you do, and I was in a panic and very distressed, I said, please, can you try again? And the doctor said, that ship has sailed. And I think this is also something we're really keen, to change, is that words matter, the way the words are written, the way that the words are said. Things like that are just, it haunts my sister and I. That it's just so casual and,
I think you also give the example of a patient who was refused antibiotics on the basis of their clinical frailty score that was relayed to you by another member, is that right?
That's correct, yes. And she was also power of attorney as well.
She had power of attorney?
Yes, and that wasn't, that seemed to be ignored.
So she wasn't consulted?
Not at all. I don't think any of us were explained what treatment, once it was COVID was diagnosed, we weren't explained what treatments were being undertaken. It was more a question of we were told what we weren't getting, so your loved one will not be ventilated. We would recommend that it's so important to explain the good things that are being done. Steroids, dexamethasone, very effective. If I'd known my dad was being given that, I would have felt, more confident that he was being treated with the right steroid or the right. It's just those. It's not a little thing, obviously, but they're relatively easy things to solve. And, one of the things I did canvass my group last night and said, what is the one thing you want me to say to them? They said, communication is absolutely vital. Clear, honest communication.
And I think there were a number of examples when there wasn't any communication from the hospitals, calls went unanswered, and loved ones and families were not being given updates either about the progress of their family member or indeed what kind of treatment they were receiving.
Exactly. We understand people are busy. When my father was dying of COVID, it wasn't a particularly busy time. But this is where you have to look at other. This is where the patient voice groups and the patient liaison teams come in, all of which seem to be, were definitely not around when during the first and second waves in Wales.
And perhaps also related to that communication issue, you set out a number of your members' concerns around DNA CPR notices during the pandemic, and in particular, a lack of communication around those decisions. And I think you give the example of one patient who lacked capacity and had, in fact, a lasting power of attorney for one of their family members, but they weren't involved in any consultation around the making of a DNA CR notice. Is that correct?
That's correct. I mean, most of us were not consulted, and most of us didn't find out there even was one placed until we got hold of our hospital notes, and that could be some months, even years later. And then also the confusion with the DNA CPR and the treatment escalation plan. My dads are contradictory to each other. The treatment escalation plan says he is eligible for CPR. His DNA CPR says he's not. Neither of them are filled in completely. And, we were told by the health board that they had tried to contact us, but that we were having our dinner. How they knew this is we've no idea. But they have subsequently apologised that they did not attempt to consult us on that. But apparently my dad was fine with it. And again, words matter. It says on my dad's CPR, we explained to the patient that CPR would be futile. I pray that they did not use the word futile to my dad, because, you just wouldn't, would you?
Also, perhaps on this subject of communication and insensitive communication, I think it's right that a number of your members voiced concerns about the communication they had from hospitals after their loved ones had died, and returning their loved ones' belongings to them. I think you give the example of one family being told to burn their loved ones' belongings. Is that right?
Yes, or they got someone else's, really, soiled undergarments, urine-soaked slippers. One lady got her husband's stuff back about a year later with two half-open packets of biscuits in them. You'd have thought that there'd just been some kind of process to check what was being handed over, usually in a bin liner or a plastic bag, and it's back to that dignity and death. These are people's lives, and I think that was largely forgotten. I think the individual was forgotten, in amongst all of the confusion and chaos.
I think you set out in your witness statement that at least four of your members, experienced the hospital morgue having lost the bodies of their loved ones temporarily and not being able to locate those.
Yes, absolutely. No, and not even a real apology. It was just like, oh, well, they've been moved to Hospital X. One of our members had to actually stop her father's body being transported to a super morgue many, many miles away. It's all about communication. It's all about respect, and it's about listening. And I think, we know there's been a number of reviews and investigations, albeit a patchwork, cobbled together list, but never once have any of the health boards or the Welsh Government consulted those that were actually there and asked us how we think things could be made better. Be it communication or infection control or DNA CPR. We've had to do that all of our own volition and lobbied very hard to get those changes.
Can we move on, please, to look at some of the issues that you've raised and your members have raised in relation to concerns around infection prevention and control measures in Welsh hospitals. I think there are a number of concerns that have been raised by your members, and this is paragraphs 40 to 50 in your witness statement, Mrs. Marsh, particularly around failures to segregate patients according to their COVID status. I think that was experienced by a number of your members. Is that correct?
Yes, there was seemingly a categorisation system of amber, green and red wards, but we all witnessed non-COVID patients being put on COVID wards. Conversely, what one of our members had both her mother and father with COVID put on a non-COVID ward, people on corridors, an inconsistent utilisation of those categories. I mean, any of us that were there, experienced it firsthand in both waves one, and similarly, particularly in wave two. There just seemed no rhyme nor reason to what people were doing. And, we hear repeatedly, I was following the IPC guidelines. We'd just have to say, well, did someone not... it's a sign of insanity, isn't it, to keep doing the same thing and expect different results? But cluster outbreak after cluster outbreak was happening in Wales, and yet nobody seemed to go, hang on a minute, are those IPC guidelines working then? Because we with the same thing, how is it still happening? How are we still having so many infections and deaths?
I think there were occasions when your members had intervened to try to ask for their loved ones not to be placed on a COVID ward. I think you give the example of a patient who was immunosuppressed and asked for them not to go on the main ward, but they were placed on that ward and contracted COVID in those circumstances. Is that right?
Absolutely. And even when somebody was with suspected COVID, they kept them on the ward until they tested positive. So that was the scenario in my dad's non-COVID ward, was that, patient 0 got it, and then everybody else got it, but they weren't testing regularly. They weren't. There was no system or structure to and we'd say IPC, the prevention, the P word. You need to prevent it first of all, and that comes back to building hospitals or starting to build hospitals with the right ventilation. I mean, Florence Nightingale was saying this 160 years ago. I mean, it's no surprise. We've got reports from 2001 from Welsh Government saying, that I think 1 in 10 Welsh hospitals were built before 1900. It's not unknown that this stuff needs to happen. So prevention is absolutely key. We know that ventilation can't be implemented overnight, but there could have been HEPA filters put in. Their efficacy had been tested, I think at the Edinburgh, Cambridge in, I'm going to say July 2020. It's not the only solution, but it cleans the air, and it's every human. It's a human right to have fresh and contaminated air, isn't it? You wouldn't build a public building without fire prevention. You wouldn't make people eat contaminated food, and yet this concept of having clean, fresh, uncontaminated air just seems to have just bypassed everybody. And I'll be honest, it still has.
I think there were also concerns around the way that PPE was being used or worn in Welsh hospitals. I think a number of your members saw healthcare workers with inadequate PPE or sometimes wearing it incorrectly, masks being worn.
Chin wearers, yeah, that's the thing, yes.
And also, I think there were some concerns from your members about the use of agency staff who may have moved between several different hospitals, and the potential to spread nosocomial infection in that way. Is that right?
Yes, and there's a number of things there. Obviously, we know, I mean, I didn't know at the time, but, the right masks weren't being worn anyway, but even surgical masks weren't always being worn or being worn incorrectly. The whole apron thing, we have no idea how an apron was going to protect you from COVID, but that seemed to be a thing. And absolutely, this is again where the consistency is required. If you've got agency staff maybe working across a number of hospitals, if there's different rules and policies in different hospitals and health boards, it's opening up the risk of human error. I mean, it's not a risk. It's likely to happen, isn't it? Because they just don't know. Oh, in this hospital we do it this way, and in another hospital we do it that way. I mean, it's just so simple, isn't it, to have a set of consistent policies that everybody follows.
And you identify, particularly in relation to IPC measures, inconsistencies in the visiting restrictions that applied in different hospitals or across different local health boards, particularly in relation to visiting around end of life. And what were the views of your members in relation to those visiting restrictions when it appeared that other IPC measures were implemented in quite a lax manner?
Well, that's exactly it, isn't it? I mean, if there would be no reason for you not to visit your loved one if you had been given an FFP3 mask, there would be no reason. There'd be no risk of you passing it to anyone else on your way to visit them. Clearly, they'd already got COVID. You would also be protected from them giving you COVID. Everybody must have someone with them when they die. They just must. And it would have been, again, a simple solution to have enabled that.
Another aspect of IPC testing, which you've touched on briefly, I think your group have a number of concerns, particularly around testing of asymptomatic healthcare workers and the delay in bringing in that policy in Wales and then implementing that policy across all of the health boards. I think it's right that some health boards had not implemented that policy until March of 2021, is that right?
Yes, and Professor Clure, who gave evidence a couple of weeks ago, said that in his health board it was actually July. In England, that was brought in November 2020, as soon as basically lateral flow tests were made available. So this enabled healthcare workers to test twice weekly, and clearly not work even if you were asymptomatic. Now, what the reason for that is, we've heard many and varied reasons, from distribution to UK government comms, didn't quite get that one. But when we met with the then Health Minister, Ellen Ed-Morgan, she told us they needed a strategy. That was why it was delayed. It needed a strategy, and it wasn't an easy thing to do to get those tests out. I mean, how it took over 6 months to get lateral flow tests when hospitals already have an established distribution network is beyond our understanding. We can only imagine maybe it was done on purpose. We don't know, but just to touch on it, it's not just the healthcare worker testing. That once they realised that they shouldn't be discharging, not realised, it was absolutely tragic that they were discharging those from hospitals to care homes without testing, but discharging to community hospitals and discharging to people's homes. When I asked why my dad wasn't tested before he was discharged, they said that's because it wasn't their policy. I'm like, but he was an old man. Where's the risk assessment? He was 85, immunocompromised. You told him you were sending him home because it was the safest place for him to be, which is great in the fact they're acknowledging that hospitals aren't safe. So at least that's one win for us. But they can't. You can't just. You've got to have. And one of the things I've written down on one of my many postcards in front of me was this lack of common sense and personal accountability. Whatever the rules were, or the IPC guidelines were, or your particular hospital, national or local, if you've got someone that's been, exposed to 20 other patients on a ward, whether it's your policy or not, you should just, because that's what you do, you have to test someone. And of course, by not testing him, that meant he's never been actually categorised as having hospital-acquired COVID because of there's many questions to be asked about that.
I think in addition to concerns about not testing patients before discharge, some of your members also had concerns that their loved ones were not tested on admission to hospital or not tested until several days had passed. Is that right?
Yes, there's many stories not on admittance, not eventually. But the other thing that Wales was very late on was the repeat testing of patients, which is absolutely vital, because obviously when you do a test, that's a point in time when you're testing. We know that the viral load is different at different points. So I think England started to do retests of patients, I think from September, and that was every 3 days. Wales did not do that, and it was every 5 days, and I'm pretty sure it wasn't until January 2021. Again, this is why Wales had so many nosocomial infections and deaths, because all of those very straightforward things that you could have done to identify someone with COVID weren't done, and then, of course, that escalated. And it's just a shame that that there's been a sort of investigation into deaths, nosocomial deaths, but by the Welsh government. But interestingly, nothing on the cluster outbreaks, which is, of course, the whole point. It shouldn't be about individual investigations. It's lessons learned has to be on how nosocomial infections start and how they can be prevented and controlled.
I think you've also identified concerns from your members about issues with the use of technology in the healthcare system in Wales, and particular problems with the IT infrastructure, a lack of integration, which the inquiry has heard about, between primary and secondary care, and also incompatible IT systems being used by different boards and different GP surgeries. And you identify some of those problems that are particularly clear in relation to DNA CPR notices. Is it your understanding that DNA CPR notices in Wales are generally paper copies rather than digital records?
They are all paper, and one of the things we really want is the digitisation of DNA CPR forms. Apparently they're on a pad, and you rip one off when you want to use it. It's not numbered, so it can't be traceable, it's not auditable, and that is then just manually attached to a patient's physical folder. So when we asked how many DNA CPRs had been placed during those sort of key points of the pandemic, we were told not possible to tell you because it would take too long it would be a sort of manual paper exercise. I mean, it's astonishing. But, also, there's good digitisation. There's a stark difference in what NHS England do and what NHS Wales do. There is that interoperability between primary and secondary healthcare in Wales. There's also, and my sister said to please tell you this, that every time my dad moved bed within the same hospital, she had to tell them the same things about his condition because they didn't know. There was no electronic way. It wasn't that they picked an iPad up and could see. It's the same thing with the out-of-hours doctors. It's just this pattern. And I'd say, I know Andrew Goodall said that the Welsh Government hit their targets on digital inclusion. Well, I'd say that's because Wales has very little digitisation, so it's a very easy target to hit. Very difficult to exclude people when there isn't much of it.
Finally, you've identified in your witness statement a number of areas that your group have identified as lessons learned and potential recommendations for this inquiry. I'd like to take you to three particular areas, if I may. First of all, you've identified the issues that arose because of the state of the Welsh NHS estate and the challenges that has created, in particular for the implementation of IPC measures. And you referred earlier to a number of pre-pandemic reports and reviews that were carried out in relation to that. So is that one of the key points of learning that your members would like the inquiry to consider? Absolutely.
And interestingly, Vaughan Gething said to stop tinkering around with hospitals, but to build the right ones. So it's great to know that the Welsh Government are listening. But absolutely, we've got a very old NHS estate in Wales. If you don't do something now, you're just building up that backlog year after year after year. If a COVID pandemic hasn't shone a light on what needs to be changed, I don't know what will. And I know it will cost money, but that has to be a cost-effective in the long run. And again, if it saves lives, that has to be the right thing. And it's also not just about patients; it's about those that work there as well. So absolutely. As well as the physical infrastructure of NHS Wales, you've also identified problems which I think we've already looked at in relation to the IT infrastructure and the way that can help with the pandemic response in future. You've also identified issues around palliative care and pandemic palliative care and the need to build into pandemic plans provision for the rapid training and upskilling of clinical staff around palliative care and particularly compassionate communication with families and loved ones at the end of life and when patients have died.
Why is it so important to your members that the inquiry considers the role of palliative and end-of-life care?
Because, again, it's someone's life. It's their last. We have to treat everyone as an individual, and our group have lobbied very successfully to get bereavement leads in each of the health boards, and we've now got permanent funding. But what we haven't been successful in doing yet is lobbying for mandatory, compassionate training for all NHS staff. And this doesn't necessarily have to be just the frontline, clinicians, but people that deal with complaints or deal with calls. As I said, for words really matter. And it also helps those that are, delivering the palliative care as well. It is so important to understand how a patient needs to be spoken to, how the loved ones need to be spoken to, how things need to be explained. I believe, again, I say this, it's a human right. It is a human right to have the right treatment when you die. When I think, my dad's death, it haunts us, my mum, my sister and I, it just haunts us because there was so little compassion. And, we were there, we weren't demanding, we weren't rude, but we were just, it just looked like they couldn't wait to get rid of us. And it's just so important to do that. And I cannot see, we're not for 1 minute suggesting we take frontline nurses off 2 weeks to do a course. We've suggested modular online courses that, they can do updates on regularly. And I'm probably being a bit cheeky here, but one of the things that we did just want to mention as a group was the lack of data in Wales. Well, maybe not the lack of data, but there's a lot of data, but maybe it's not interoperable and it's not the right data. But for us, data itself has no value. It's what you do with the data and the questions you ask of the data. And the data, in our view, is required to tell the truth. And if it doesn't tell the truth, it's useless, isn't it? And it can't be, you don't want it to be manipulated for the wrong reasons. So we really want there to be, I don't know whether the Welsh Government need a chief data officer or health boards need to, liaise more, but there has to be the right use of data. And I feel like I hear about it a lot. We need good data. That's sort of fairly meaningless. I think what we're trying to say is we need the right data in the right format and for it answer to the right questions and then to be actionable. And that's the key thing here.
Thank you very much. Mrs. Marsh, I've no more questions for you.
Could I just say one thing? I just wanted to say we've seen a lot of people in the inquiry that, sort of a lack of accountability or, and contrition. But what we wanted to say was a massive thank you to groups like CATA, John's Campaign, Clinically Vulnerable Families, long COVID groups who have, outside of their day job, passionately, tenaciously fought to get the right, to expose the truth that COVID is airborne and many other things. And I think we need to have to call on our leaders, government and healthcare leaders, to stop the gaslighting, stop the scapegoating, own it, take action, and stop this happening again. Thank you very much.
Thank you very much indeed, Ms. Marsh. As ever, extremely helpful and constructive, and I'm really grateful to you. You talked earlier about how the individuals we've lost will be forgotten. Well, as long as there are people as articulate as you are, advocating on their behalf, they'll never be forgotten. So thank you very much indeed for all your help.
And thank you for my mum and sister and my dad too.
Thank you.
I
think it'd be best if we take a break now, Miss Neild, is that right? So that Ms. Marsh can speak to those who represent her and others. And I shall return at 11 o'clock.
Thank you, my lady.
Good morning, my lady. May we please call Margaret Waterton?
Thank you, Mr. Scott.
I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
Shall
the
be
whole
the-
truth, and nothing but the truth.
shall be the truth, the whole truth, and nothing but the truth. Thank you.
Ms Waterton, I hope you heard what I said earlier. I'm so sorry I can't be with you in person, but I shall be paying very close attention, obviously, to everything you say, and I'm really grateful to you for coming along.
Thank you, my lady. Totally understand, and we hope that you're fully recovered soon.
Good morning, Mrs. Waterton.
Good morning.
You're a member of Scottish COVID Bereaved.
That's correct.
And I think you're particularly keen to give evidence today on behalf of all of the members of Scottish COVID Bereaved and give the inquiry a sense of how the majority of the members feel and how they're impacted by the pandemic. Is that right?
Yes, that's correct.
Just dealing with your own personal experience of COVID bereavement, I think you're right that your mother died on the 18th of June 2020 as a result of a nosocomial infection, and your husband died on the 2nd of January 2021, less than 2 weeks after his 71st birthday.
That's correct.
Would you please describe how it feels to have lost someone to COVID-19 during the pandemic?
It's devastating. Any bereavement is devastating in its own right. But the complexities, the restrictions, the situation that we had to experience and endure, and our loved ones had to experience and endure, make that so much worse. And we all feel the trauma. We feel self-blame. We feel guilt that we could have done more to protect and shield and save their lives, and that we should have done more to do that. And we are tortured by it every day. I'm haunted by it every day.
Did it feel different being bereaved due to COVID compared to in non-pandemic times then?
I've been reflecting long and weary on that, and my father died in 1999, and I wasn't there with my father when he died. My mum was, and the inability to be with the people that we loved the most while they were taking their final breaths in this life, to offer them comfort, to tell them how much we loved them, that was taken away from us. And I feel entirely different about my father's death and the circumstances surrounding that. I have come to terms with all of that, but the circumstances that we were in, being excluded, being kept away. We have members who were told that they could be with their loved ones when they died, but if they did that, they wouldn't be able to attend the funeral. So that was a Hobson's choice. That was no choice at all, because those two things were vitally important to us. There were restrictions around the funerals in terms of numbers. Everything was forbidden, and it was all related to it's all because of COVID. So those things we haven't been able to do. We haven't been able to put people to rest properly, is how we feel. And that's the difference between being bereaved by COVID and before. And yesterday I went to the National COVID Memorial Wall and I found the hearts for both my mum and my husband. And I put my hands onto those hearts. And 2 feet away from me, were dozens of tourists taking selfies in the background of the Houses of Parliament while I'm weeping. And that's the difference, because we understand what it is to have been bereaved by COVID. But for the majority of the world, the rest of the world, COVID is forgotten.
I think the 3 main areas that Scottish COVID Bereaved wanted to talk about are DNA CPRs, nosocomial infection, and then visiting restrictions. Is that right?
That's correct, yeah.
I'll deal with nosocomial infections first. How big an issue was nosocomial infection in Scotland during the pandemic?
Well, for our members in Scottish COVID Bereaved, it's one of the main issues that we are facing. 1 in 4 of our members lost loved ones to nosocomial infection. So it's a significant area. And we are particularly glad that this module is looking at nosocomial infection prevention and control in depth. Nosocomial infection was an issue in Scottish hospitals right across Scotland pre-pandemic. And we heard evidence from our previous Cabinet Secretary for Health and Social Care, Mr Yousaf, who said in his written evidence that hospitals were safe and sterile environments. Well, during the pandemic, they were never safe. They were places of high risk because of the risk of hospital-acquired infection, nosocomial infection. Hospitals have never been sterile environments in their entirety. Yes, of course, you can have sterile theatre, for example, but they're not sterile environments. And the pressures on Scottish hospitals, the contributory factors of nosocomial infection, include the capacity at which the hospital is working. So Scottish hospitals were working well over 90% pre-pandemic and then exacerbated in the pandemic. Patient movement from ward to ward, commonly known as boarding, was also a major issue and well established in research as a contributory factor to nosocomial infection. Asymptomatic transmission was not recognised quickly enough. So patients were in non-COVID wards but were asymptomatic. Testing was insufficient in terms of capacity, the timing of getting the test results back. Some of our hospitals in the Highlands of Scotland had to wait a week to get a COVID test result back for a patient, by which time, of course, the infection has spread. Availability of PPE and the nature of that, and we've heard lots of evidence in this particular module about the reluctance of Scottish Government to accept that COVID was transmitted via the airborne route and focused entirely on droplet. So the provision of PPE was inadequate for all of our healthcare staff who gave their all during the pandemic.
Let me just bring you back to what you were talking about with the Scottish estate. So those features that you've just been describing that made up the reason why there was nosocomial infection to the level it was in Scotland, how many of those features do you think were unique to Scotland and how many of them were across the United Kingdom?
None were unique to Scotland, all were across the United Kingdom. None were unique.
And you mentioned the evidence earlier on of Mr Yousaf. I think you also had some observations about the evidence of Ms Freeman in relation to nosocomial infections.
I did. I heard, or we heard in her evidence, that she was asked a question by counsel around what she understood the main cause of nosocomial infection was. And her response to that was it was poor application of IPC practice. And I think that did a huge disservice to our healthcare workers who gave their all during the pandemic. Some gave their lives to the pandemic. And it completely ignored the other contributory factors that I've already mentioned. And of course, staff movement, as we've heard from my colleague previously, bank and agency staff and so on, also moving from place to place, IPC guidance being changed frequently such that staff had no real chance to keep up with it. And as I say, the situation that's been well explored in this module around the availability and the appropriateness of PPE.
I want to look now at DNA CPRs, Dan. Your statement sets out that there's a significant concern about communication about DNA CPRs in Scotland. What is Scottish COVID Bereaved's number one concern about how DNA CPRs operated during the pandemic?
That there were times and situations, and our members can attest to that from their lived experience, that not only was the discussion around DNA CPR not had with family members, the next of kin, people with power of attorney and so on, but that DNA CPR consent was gained inappropriately. And if I may use my own mum's situation, when my mum went into hospital for the very first time with a chest infection, she was in hospital for 4 nights, 3 days, came home, and in her bundle of belongings, I found a DNA CPR consent form. And when I asked my mum what that was and did she understand what it was, she first of all couldn't remember. When I explained to her what it was, she was absolutely horrified at its meaning. And once she'd had time to gather herself, she was able to recall Now, my mother was admitted in a state of delirium with very high temperature, and therefore, in my view, she did not have capacity to consent to DNA CPR. She had signed the form and she remembered doing that, but what she said to me was, I didn't understand what the doctor was telling me, and I felt that she was putting words in my mouth. Now, I complained to the health board about that, and the response indicated that it was a junior doctor who had acted inappropriately, and that would be dealt with locally by the medical director.
But just in terms of general communication as experienced across the whole of Scottish COVID bereaved, was it a concern about discussions not being had with families, or was it discussions with patients?
Both. Some of our members were completely unaware that DNA CPR consent had been arrived at until some considerable time after their loved ones had died, and that might have been by looking through, finding the medical notes, looking through the notes, or some other means. And almost without exception, DNA CPR communication was poor. Again, I had two different experiences of that, where it was handled very, very well, compassionate, clear communication, very clear what the rationale was. And in another situation with my husband, I was being asked to determine how far he could walk. So we are not clear about how these decisions were being arrived at, and there's concern that they were being intertwined with treatment escalation plans and used as a proxy for no escalation of care.
Because your statement sets out that there were guidelines in place in Scotland, I think well-established guidelines is how they're described, about how the process should operate.
Yes.
Do you think that during the pandemic there was a lack of clarity in what the guidelines said should happen in terms of communication about DNA CPRs, or that the guidelines were cleared but they weren't always being followed?
I think there was a plethora of guidance for clinicians around DNA CPR, treatment escalation. And I can only imagine what it was like in terms of pressure for clinicians during the first and the second waves, and the amount of decision-making that they were having to do.
Just to pause you there, you had been a nurse yourself for a number of years, is that right?
I had been. I was a registrar with the NMC for 39 years.
So you have an understanding. And there are other Scottish COVID bereaved members who are healthcare workers?
Yes, we have several healthcare workers as our members. I understand, or we understand, we can imagine the pressures, but the number of our members who were not communicated with about the decisions that were having to be made about their loved ones' care, ongoing treatment and escalation of care, and DNA CPR are the majority. So there are huge concerns that it's not just about poor communication, but how that guidance was being applied in the moment.
In the event of a future pandemic, what do you think should happen in terms of communication about DNA CPR decisions?
I think if I might take a step back, and we've heard evidence in this module around the respect form, for example, and that was used in variation across NHS Scotland. It wasn't used consistently. So I think there's something around a recommendation, if I may make so bold, for the formulae and the inquiry around whether it's respect or whatever it is, but across the nation, that can be used consistently with clear guidance underpinning it, that is based around care, compassion and person-centred approach.
I want to move now to visiting restrictions, please. Do you think that hospital visiting restrictions in Scotland struck the right balance during the pandemic between maintaining infection prevention control measures and allowing families to visit their loved ones in hospital?
I think we understood and we understand that the nature of the pandemic and the virus at the outset wasn't entirely known. And of course, footfall needed to be reduced. We understand that. But we have heard consistently through the module, particularly from the chief nursing officers of the 4 nations, about visiting restrictions and the guidance around that, and that individuals at end of life were to be enabled to have their loved ones with them in their last moments. And that was not consistently applied across a ward, across hospitals, across health boards. And we were denied the opportunity, and so were our loved ones denied that opportunity for us to be with them, to offer them comfort. And I've been described as lucky because I was with both my mum, I was enabled to be with my mum and my husband when they died. And I don't consider myself lucky. I consider that that was my right to be with my mum and my husband when they were dying, to offer them as much comfort and love and reassurance as I could in their final moments. And it was equally their right to have me there, and extrapolate that across all of Scottish COVID bereaved. We all had the right to be there. We all had that right, and it was denied us because the guidance was not consistently applied. And if we link that in our heads, because that's where we've got to wonder, to DNA CPR discussion, escalation of care, we weren't there. We were trying to determine what was happening to our loved ones remotely. We couldn't see them, we couldn't touch them. The deterioration was not obvious to us, and that would have enabled many of us to have understood what was happening to them in a much kinder way. And we've heard about moral distress, moral injury from BMA and RCN in particular during their evidence. And we understand that. But I wonder how much of that we could have helped reduce, minimise, avoid if we had been there with those that we loved the most when they were dying.
Do you think there was enough care and compassion being built into how the visiting restrictions were being drafted?
Not consistently. I think we think that it was all about the mechanics of it, and we understand about reducing footfall, and we understand the difficulties of members of the public, ranging through hospitals and so on, and not adhering to IPC guidance. And many of our members saw that. I witnessed breaches of infection and prevention control practice in staff. Many of us witnessed that in all aspects. We understand that, but all of those chief nursing officers said that the guidance was to be applied in an individual way and compassionately. And that's not been our experience of that. Members whose loved ones were on life support and the life support being switched off while they're on the phone. Why couldn't they have been there? Why couldn't they have been there? But that loops back into the you can be in for 15 minutes, but then you can't go to a funeral. And that's a Hobson's choice for anyone to have to make. But particularly when we're watching the media online, scenes from Italy, were there enough ventilators? Was there enough piped oxygen? Was there enough staff and PPE? All those things where we were wondering about and how that impacted on visiting, whether we could actually wear PPE to visit, whether there was enough to supply that to us as visitors. And how was that decision-making happening? What was impacting on the decision-making? So it wasn't consistently applied. And I have to say to you that as a nurse for all those years, whilst I admire everyone in healthcare who was working and giving their all, we lost care and compassion, and we must work hard to get that back.
Were the reasons why there was a different application of visiting restrictions within individual hospital wards across Scotland, were there ever any explanations given as to why they were being applied differently?
No. That was very much down to the local discretion of a ward or an ICU or that clinical area. And so it was up to the individual who would be in charge of the ward at that time, for example. So there was no consistency around it at all. And that then leads to that we all had a different experience of it, and we should have been able to be clear and be sure that when our loved ones were dying, we would have been allowed to be with them, 100%.
just leaving aside the end of life for a minute, just generally in terms of visiting in hospitals, do you think there would have been a benefit to the Scottish COVID bereaved members if there had been explanations about why in certain circumstances the restrictions needed to be tighter, or in certain places they needed to be tighter than in others?
Communication is key, and clear communication would have been hugely beneficial. So if, for example, there had been a cluster of COVID cases in a particular ward, an outbreak in a particular ward, then that's explanation enough about we need to manage this in a different way, and we need to. It happens if a ward, for example, or a hospital has an outbreak of norovirus. That happens. So why couldn't it have happened with COVID, so that we were much clearer about the necessity for the level of restriction that was put in place?
I want to talk now about use of technology as a substitute for visiting. You describe in your statement how technology such as tablets and mobile phones were often used to allow contact when visiting was not permitted. How well did that function in Scotland?
I think, again, that was variable. There was huge reliance on individuals having access to mobile phones, tablets, whatever, and that they would be able to use them. But the Wi-Fi connection in many of Scotland's hospitals is entirely variable, and not every ward has good connection, not every room in every ward has good connection. So there was that whole sense of digital exclusion, and people going into hospital with COVID were very seriously unwell. They would be receiving oxygen through full face masks. So if you wear glasses and you're then forced to wear a full face mask to have high flow oxygen, you can't see. So you can't see to use a mobile phone, you can't see to use a tablet. If you're having to be placed in the prone position for periods of time during the day to try and help your oxygen saturations, using technology is not possible for you. And there was just a huge reliance on the individual. At the same time, we were watching the media telling us that tablets were available everywhere, in wards, in ICUs, and staff would use them. When my mother went back into hospital with COVID, a nurse used her own mobile phone to help me have a WhatsApp call with my mum. And that was the one and only time in a week that I was able to see and speak directly to my mum.
You just used the word see there. When technology was being used, how important was it to be able to see the person rather than just being able to talk to them via phone call?
It's vital, because you read all sorts, you see all sorts from each other. And looking at a well-kent, well-loved face was hugely comforting and reassuring. And when I looked at my mum on that call, I was reassured, because I thought, oh, she doesn't look as sick as I thought she might. So there was a level of reassurance and comfort from both sides. And my mum was glad to see and hear me. I had to speak with my husband over the phone and try and reassure him. He was terrified. People were terrified of what was happening to them in hospital. My mum said, if I get that COVID, I'll be a goner. And she was right. She knew with her respiratory conditions, she would not stand very much chance of surviving. And my husband was terrified, because I think he knew what was potentially lying in front of him. And when we had both had COVID and been unwell, we were both worried that each was going to die. The outcomes were unknown. So that seeing individuals is so vitally important, because we can see a smile, we can see a reassuring look, and we're comforted by that.
Can you think of any way that it would be possible for more video calls to have been used during the pandemic, or was it simply a reflection of the capacity of healthcare workers to be able to facilitate that?
I think it was a reflection of their capacity. the digital ability in the hospitals and that whole sense of digital exclusion.
Did the health boards, whether across a region or for individual hospitals, for example, provide any information about the best way to use technology as a replacement for visiting?
No, not across our membership, not in any real sense.
Do you think that would have been beneficial?
I think there was I think it would have been beneficial, but I think there was an expectation in this day and age that everybody has a mobile phone, can adequately use it, that everybody has access to a tablet or whatever device of that nature and is able to use it. And I think there was an assumption that would all work, when in fact, when people are sick, those are the last things they're going to be able to use.
Just going to move away now from visiting restrictions. Is there anything else that you wish to say in relation to visiting restrictions, how they were applied, consistency, use of technology that you haven't already covered?
No, I think we've covered all of them.
Just going to ask then about COVID hubs, assessment centres, access to GPs. I think COVID hubs and assessment centres were used in Scotland, and your statement sets out how they functioned, what they did, and what they were meant to achieve. Did the Scottish COVID bereaved find them useful in principle to have these Scottish COVID hubs?
I think in principle it was a really good way of enhancing primary care and triaging individuals who either had tested positive for COVID or had COVID symptoms. I think in principle it was a really good step, and it was there to support. In Scotland, NHS 24 runs the 111 service, and it was a really good positive move to enhance that primary contact with healthcare, because across the nation everybody was being told to stay at home, protect the NHS, save lives. And there was in our membership, there was a real struggle trying to get hold of GPs, particularly to see them face to face. Have them do a home visit was almost impossible. And calling 111 was a very variable and mixed experience for our members, some of whom, because they didn't have the three main symptoms and had other symptoms, were being told that you don't have COVID and don't be, come back to us if anything worsens. I think the issue going forward, if we were to have things around COVID assessment centres and hubs again, is the means by which you access them, by which you're transported there. Because in Scotland that was, it was taxis that were used in the main to transport people from home to the assessment centre and then back again. It was taxi drivers who were doing that, and they were really brave and courageous, but they weren't allowed to offer any assistance whatsoever. And if you're needing to go to a COVID hub, you're pretty unwell. So there needs to be thought given about that transport. In fact, one of our members, her brother was to go to a COVID hub and was so unwell he couldn't manage fully down the length of the garden path and was hanging over the garden fence, when at the same time the COVID hub transport arrived and an ambulance, because his condition had deteriorated and his family had called the ambulance, and the ambulance crew wouldn't take him and stayed in their vehicle, and he was transported to the COVID hub in the taxi and then ultimately taken to hospital.
So would it be fair to sum it up that in principle these COVID hubs and assessment centres were a good idea and functioned well, but how they actually functioned in practice is a different matter?
I think so. I think they were a good asset, but just needed further work and refinement as to how they actually were operationalised.
And you mentioned earlier on about GPs as well. How accessible did Scottish COVID bereaved members generally find their GP surgeries were?
I think overall the view initially certainly was that GPs, surgeries, health centres were closed, and it became very difficult to access a GP face to face. Some of the near me stuff in NHS Scotland wasn't functioning in every health board. Home visits from a GP. So again, if I just, one of my mother's first comment actually to me was, if I need the doctor, how will I do that? Because she believed from the messaging that she couldn't access a GP at all. So there's a mixed experience again, but home visits, very difficult to secure, and seeing a GP face to face. So telephone consult, video consult. But there are many things a GP and doctor has to lay hands on and can't do over the phone.
But broadly, did remote GP appointments work across Scotland, or were there difficulties with how they were set up, how people were able to access them? How did Scottish COVID bereaved members find them? Again,
a mixed experience. And one of our members, for example, their family member had several repeat telephone consultations with repeat medication happening. And when eventually that individual did manage to have a GP appointment and then required to be referred to hospital, and they had an underlying cancer that hadn't been picked up for some months. So a mixed experience. Again, I would say that if I might just use my mum as an example, when she had developed COVID, one of the things we were asked to do was to get her own GP to come and visit her. And it was her family GP who came to see her. And the reassurance that provided for my mum was significant.
I want to ask you about the experience of Scottish COVID bereaved where family members were discharged from hospital, not to care homes, but they were discharged home, about how Scottish COVID bereaved found the experience of discharge and what it was like looking after their family members.
Again, a mixed experience, but individuals, we've heard already about individuals we were unclear whether our family members had been tested, whether they were COVID positive or not. And indeed, we have one member who his wife was discharged after 2 days with COVID, and she was seriously unwell, and subsequently she died. So again, that mixed experience of not being clear what the status of somebody was when they were being discharged, not sure whether they had been tested on discharge to protect family members. And remember that some of our members were shielding, some of our members were immunocompromised, unwell, frail, and so there was a situation where you just weren't sure what was going on, and then the impact of that on the wider family, COVID, and the situation I've just articulated.
Okay. And then finally, in terms of shielding, you just mentioned that some of your members had been shielding. What was the experience of Scottish COVID bereaved in terms of either themselves or their family members of shielding?
Shielding was a hugely isolating experience for those of us who were shielding in our group and those of us who had family members who were shielding. And it had a huge significant impact on emotional well-being as well as physical well-being. But that group probably make up quite a component of our number who developed nosocomial infection. And that group of individuals were hugely protected at home, but they were the most likely to have to seek hospital care and to be hospitalised. And at that point then they're plunged into a hospital environment where there is no testing, huge patient movement, clusters of COVID, outbreaks of COVID, patients with COVID and non-COVID wards, and they become hugely vulnerable to it. And indeed, that's actually what happened to my own mum. She was admitted to hospital, and there were 4 patients in what I understood to be a non-COVID ward, a care of frail elderly ward, and that's where my mother contracted COVID.
You set out in your statement some lessons learned that the Scottish COVID bereaved hopes that Her Ladyship takes on board when considering the evidence. Is there anything on behalf of Scottish COVID bereaved that you hope Her Ladyship bears in mind while she's considering both the oral evidence and the written evidence that she's heard in Module 3?
My lady, we are so grateful to you for your work, and we look forward to further robust, clear recommendations with clear accountability. And for us, that's one of the things that we seek to achieve is truth, justice and accountability. And accountability isn't about blame. Accountability is accepting responsibility for what's yours to own. And we have heard previously and recommendations around hospital estate, ventilation. We've said in our statement around the workforce plan in NHS Scotland to make sure that is robust, that staff are prepared, enabled to function in a pandemic, and that care and compassion come back and person-centred care come back into that workforce. Communication, we've again heard about ventilation, HEPA filtration, and we've got very old estate. We're not alone, but we've got very old hospital estate in Scotland. And whilst we don't expect that you're going to be able to instruct that new hospitals are built immediately, there has to be something that's done to take away the Nightingale wards that still exist in our hospital estate in Scotland. Care and compassion, DNA CPR, and how that is managed, handled, communicated. And those, for us, I think, are the main issues.
Thank you. My lady, no further questions.
Thank you very much indeed, Mrs. Waterton. You've got through a huge amount extremely efficiently, and I'm really grateful to you. And I promise, as I'm sure you accept, that I'll do my very best to bear all the matters you raise in mind, and if I can, come up with some recommendations. Of course, it'll then be for others to implement them. So it won't just be a question of what recommendations I can make, but it'll be in getting the support of people to get them implemented. That's where some things sometimes fall down. But I promise to do my very best. And thank you so much for all the help that you've given to the inquiry and the support that you've given to us.
Thank you, my lady, and we wish you a speedy recovery, and we stand ready to assist you and the inquiry going forward.
Thank you very much. Well, we take. I should come back at 10 to 12, so you can talk to your representatives.
My lady, good morning. I'm taking the next witness, who is Dr. Saleyha Ahsan.
Thank you, Ms. Carey.
Just put this after me, please. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth and nothing but the truth.
the whole truth and nothing but the truth. Thanks.
Dr. Ahsan, I'm truly sorry I can't be with you in person, but I promise you it doesn't mean I'm not going to pay huge attention to all the help that I know you're going to give. So thank you very much.
Thank you.
Dr. Ahsan, your full name, please.
It's Dr. Saleyha Ahsan.
Dr. Ahsan, I'm going to ask you about 2 witness statements, one that you've prepared for the inquiry, and also one that you're going to speak to from Matt Fowler, who was a co-founder of COVID-19 Bereaved Families for Justice UK. Can I just ask about you firstly? You lead the healthcare worker group within COVID Bereaved Families for Justice UK, and I think you are a doctor by background in emergency medicine. You have a PhD You are a PhD candidate at the University of Cambridge on the subject of delivery of healthcare. You're part of the Royal College of Emergency Medicine in their EPRR committee, and you are a former British Army officer commissioned into the Royal Army Medical Corps. And you are going to help us, I think, in respect of a number of matters that touch on you speaking on behalf of the group, you speaking on behalf of your experiences as a doctor, and also, sadly, your experiences of the death of your father and the impact that's had on you and the family. So take it nice and slow, please, Dr. Ahsan. And can we start, please, with some of the wider observations from COVID bereaved Family for Justice UK. And I think you say in the statement that there are around 7,000 members, all of whom have lost a loved one to COVID-19. And that the campaign was founded in March 2020 with the purpose of learning lessons throughout the pandemic in order to save lives. And is this right, that COVID Bereaved Family for Justice UK has campaigned for improved accessibility to bereavement support, policy reviews to prevent avoidable mistakes, and continues to empower its members to hold the government and public bodies to account? And I think it was your group that helped create the National COVID Memorial Wall. Indeed, we just heard the last witness speak about that.
That's correct.
Can I start, please, with some of the concerns of the group in relation to NHS 111 and the 999 service, please? And I think you say that a number of the members are critical of the way that 111, firstly, function. What were the concerns of COVID Bereaved Families for Justice members?
So whilst speaking about this, again, it's not from my perspective as a clinician, but representing the group. And also just to say that this is, unfortunately, we've all been brought together by this unifying factor of having lost a loved one. So we didn't know each other before. We've sadly become a member of this group that no one wanted to be part of. But through being part of the group, we've got to hear about everyone's stories and experiences, and gaining an insight into everyone's journey through this horrendous time. And one of the aspects was the encounters with 111 and 999, calling for help from home. And it was quite clear from the accounts of people within the group that access to these services was at times really, really challenged. Not everyone could actually get through on 111, that there were delays, that sometimes the advice wasn't clear, and that trying to get access to urgent care at home sometimes didn't happen. And the order of events of how to get a clinician to come home, whether it was calling 111 first and then a GP coming, or which order it came in was sometimes confusing.
I see. So I if I understand you correctly, was there a tendency sometimes to ring 111 to try and get a GP, but sometimes the GP would say, I'm not coming out until you've rung 111, a sort of stuck between the gate post and the gate. Is that really what you're trying to tell us?
I think that's what some of the accounts from some of the members have been. And bearing in mind that this is a UK-wide group, so different experiences, it appears in different areas.
Yeah. I think...
and again, with the difference between rural and urban, where access to services can be challenged by distance, whether it's a very rural location versus an urban one where things might be more accessible.
I think you say in the statement that some of the members certainly consider that those who died of COVID-19 could and should have had access to treatment earlier, but the advice of NHS 111 was to stay at home. And that will resonate with her ladyship because we've heard about an HSIB report into 111 and some of the concerns there. Was there any concerns raised amongst the members about accessibility for those who were perhaps not so proficient at either ringing 111 or providing care at home, perhaps for those who are either disabled or whose English was not the first language?
I think those challenges exist even pre-COVID, to be honest. 111 had reported in the media over the years different sorts of challenges, but we had, I think, generally within the healthcare system, we knew it was challenged, and different parts of a very complex system, different branches and different systems within an overall complex system were challenged. And when we hit COVID, those challenges didn't go away; they were actually increased. So you had 111 that during busy peak periods, every winter, for example, every time there was, Christmas, New Year, etc., those peak times of other infectious diseases that were rife within the community, we had, and I speak drawing on my background within emergency medicine, these were not new challenges, but they were heightened and more severe within COVID. So it was as if there was, we were already running on nearly empty, that there was nothing left in the tank by the time COVID came. So these kinds of experiences, unfortunately, happened, and I'm not surprised that they happened. And I just feel so, and having been, just because I'm a healthcare worker doesn't mean that I haven't had to use or for my family draw on the emergency services for our own care. So when you have the knowledge of what's needed and you can't get that help through the door, it's really distressing. And so my heart really goes out to people who had loved ones in desperate need of someone with medical knowledge arriving to give help, and they couldn't access that. The minutes would have dragged like hours, and the hours would have dragged like days as they waited for someone to come, and there was no one to come.
I think in short, the concerns about NHS 111 and D999 was, could I get through in the first place? How long did I have to wait if I was going to be answered? And then what was the kind of quality of the advice I was given once I managed to get through? Does that sort of fairly encapsulate the concerns of COVID-bereaved families members?
I think that has been the overall theme of the concern, yes.
And you say in the statement that picture with regard to access to GPs was mixed. Some GPs would conduct a home visit, but some patients asked for a home visit, is this right? But in fact, the GP would not go to see them. So again, perhaps a slightly inconsistent picture across the UK and across your membership. Is that fair?
Yeah, I think that is fair. And again, as I said before, different regions and different areas of different stresses and strains. We have, if I may, her name is in the statement, Helen Brewer, who talks about her mother in North Wales and Deganwy. I was actually clinical in North Wales, so I can speak with some knowledge of what it was like to deliver primary health care in areas that are more rural. It can be challenging.
Well, tell us about then, since you mentioned, and can I just say whilst we're on that, we are very grateful to COVID-bereaved Families for Justice because the statement is peppered with real examples from your members. I wasn't going to go through them all, Dr. Ahsan, but you mentioned Helen Brewer's there. But from your perspective, what was it like trying to, in COVID times, deliver primary healthcare in a rural setting?
Okay, so I see this from the perspective of not being a GP, but being an emergency medicine doctor, but knowing many GPs. In fact, I have two siblings who are GPs, but they work in urban settings. Trying to, I think, GPs were stretched. They, like many other sections of the health service, and they were looking after vast numbers of people. People were... again, this is not taking away at all from what Helen Brewer experienced with her poor mother. But from my understanding of it and from what we were witnessing, there was a strain on the services. That, again, no one's going to find that like news that GPs were under pressure. But during that time, we had a lot of people within the community that would need some sort of input, didn't really want to come into the hospital in the way that they normally would have done, come into A&E because they were afraid of what was, lurking behind the front doors in terms of COVID. Or I had patients who clearly were unwell and should have come in, but thought that their condition would get worse if they came to hospital. In the case of Helen Brewer, her mother became unwell. It turned out to be COVID. They did try to get access to the GP. They called 111 many times and without success. It took a while. The dates, and when you look at the dates between the 16th of March and the 23rd of March, that's just a horrendously long time to be so desperately worried and deteriorating and alone, actually. And then, as she says, that the GP did finally visit, and then she was the mother was immediately sent to Glenclwyd Hospital. But I to the nearest hospital. I was found to have COVID, but it's the agony of the wait that will be really horrendous. That's an account of one of the members, and that's what I want to relay, because that's their experience and their story, and that's what they went through. The unpicking of why and what is another matter, but that's what they went through.
Well, I think you say or Mr. Fowler does in his statement, certainly, that a number of the members of your group provide accounts of people dying at home as a result of deciding not to seek medical assistance, and increased deaths, obviously, through things like delays to cancer treatment and the like. And her ladyship's heard a number of pieces of evidence that echo that experience of your members. Can I ask about those that then got into hospital? And I think particularly there is a concern amongst COVID bereaved members about hospital-acquired infection. And if it helps you, Dr. Ahsan, I think it's your paragraph 36 in your statement, and there's a number of accounts set out there about concerns about it, but just help us. Are you able to sort of give us an overview of the COVID bereaved concerns about hospital-acquired infection and what could be done to try and reduce it if it's not possible to minimise it entirely?
I think, again, and I speak as not an infection control expert, it wasn't my role, but each healthcare provider did, and we do operate within our sort of realm of infection control. But again, infection control of the whole hospital had designated roles, but personnel that were put in charge of doing that. Absolutely. Hospital-acquired infection, from the perspective of the bereaved group members, harrowing stories, accounts of people coming in with one condition, really in need of hospital care because other things didn't stop during COVID. Other conditions, other needs for hospital didn't stop. So people, for example, in the case of Andrew Ireland and his wife Susanna, she needed to come in because of acute pancreatitis and becoming quite unwell, needed to come in, and that is a condition that can make people very, very sick, and they can need intensive care for this care. She had that treatment, but unfortunately acquired COVID-19 during that time, which, again, just horrendous. And from a perspective of what it was like working in hospitals, where that was a constant worry. I mean, that wasn't something that was taken lightly. That was a constant worry of patients acquiring infections when they'd come from for a different reason. And often, you know, at that time, really only the very sickest were coming in or who needed to be in hospital, and then to actually, you know, they were already on a back foot with their health anyway, and then to have the risk of COVID.
Can I just pick up on something you've just said there? Because obviously, clearly, PPE is one of the ways that we can prevent infection. And I think it was June 2020 that face masks were made mandatory for staff and face coverings were made mandatory for patients and visitors, providing the patient could tolerate it. Do your members have any views about whether that was brought in too soon, too late, struck the right balance? Can you help with that, Doctor?
I think generally within the group, I think the overall consensus was that many of the steps were too late, too slow, lots of confused messaging coming centrally. I refer to some of the comments, press conferences, for example, interviews that were done by the Prime Minister at the time with the Deputy Chief Medical Officer, Jenny Harris, having a whole discussion about whether we should be wearing face masks or not, which, as a healthcare provider, and amongst other healthcare providers, we felt that was really confusing the message of what people should be doing and shouldn't be doing, when really, if we looked at other countries who had a tradition of face mask wearing, for example, or where steps were taken earlier with less confusion and less dithering, if I may say, that their outcomes were better. So I think by the time June had happened, the horse had already bolted. And not only had it bolted because of infection spread, but also the mindset of people. So rather than it becoming something that people thought was the right thing to do, protective of themselves and others, there was an onslaught of debate and discussion that carried on long after it was made mandatory. You still had people who were reluctant to put on face masks, and I know this from the fact that I work in television as well, and I was asked quite frequently to come on and have debates about whether we should be wearing masks or not, whether we should be having lockdowns. Often, within the other perspective would be from someone who had no real health background, but just was a broadcaster who spent a lot of time on Google reading evidence incorrectly. So I feel by June it was too late. I feel as a group we also have that consensus.
And I think there was also concerns raised by a number of the members of the group about the lack of consistency in the way that some NHS staff use their PPE, not across the board, clearly. And we might look at some examples of that from your own experience in a moment. Can I just ask you about shielding? Because I think a number of members of the CBFJ UK group were shielders. And certainly they were concerned about information that was provided to them, the quality of it, and indeed that they may themselves have to go into hospital and therefore run higher risks of catching COVID. Is there any consensus among the group about how best to relay information to those who are shielding, or any practical things that you've been asked to relay to us about how it could be improved?
Improved in terms of how to shield?
The communication that was given to shielders.
Okay. I think, again, from the perspective of my own father, I remember him and one of my siblings who also had to shield for health reasons, that a text message came through to say, but it was... And again, trying to remember the dates and the timings, but I just remember it feeling quite late, and definitely for the second wave. In the second wave, I had decided I was working in intensive care in North Wales, but I was also making a documentary for Channel 4 about COVID, and what was coming, the second wave, and we knew that it was going to be bad. Hence, I'd managed to get a commission to make the film. I didn't need a crystal ball to say, no, how bad it was going to be. But I had made the decision around about sort of towards the end of November, December time, to go home and impose a lockdown on my father, even before national guidance, because I could see the direction of travel of this. Unfortunately, I was a week too late, and he caught COVID, and it was during the Partygate season. So I think that the messaging on shielding came too late for many, especially during the second wave, and I think that's unforgivable. We had been through the first wave. If we were going to be generous at all, we could say, okay, this was the first time, but the second wave is a disaster and had some of the worst figures out of both, I think, periods, both waves. But I think, again, text messaging, that's an effective way, but and I think now people would know what that means, but in the beginning it was challenging. But also, I think it also caused anxiety, a lot of anxiety about shielding, which I think has, and this is also part of what the Bereaved Families Group are calling for, better support for mental health and well-being after the event, because I think there's a lot of anxiety of what people can and cannot do now, even when they can go out, when they can't go out, who they can be with. Again, but that side of it has now suddenly all gone away, as if it doesn't exist, but it very much still does exist, and we're still getting quite sick people coming to emergency departments with COVID or other respiratory sort of viral illnesses. So the whole area of shielding, I think, as a group, we think could have been done better, and I think it's suddenly now all gone away without any further advice.
Much of what you said there will echoes what we heard from the clinically vulnerable families witnesses and their evidence they gave us. Can I turn to your father, because he picks up on a number of issues that I'd like to ask you about. Just before we go, I think, is this right, that at the beginning of the pandemic, you were working in North Wales, is that right? And during the first wave, you worked for Public Health England doing shifts at Heathrow, certainly monitoring those that were coming into the UK at the time when we still could travel. And then certainly you say in your statement that in February 2020, you were on a shift in North Wales and asked to respond to a call from passengers on a train coming to North Wales from Scotland. And the passengers had been around someone with confirmed COVID. At that point in time, there were no recorded COVID infections in the North Wales area, and you wanted to seek some guidance on what to advise the passengers and where they should go and what they should do. And what happened when you tried to find out what you should advise the passengers?
Yeah, and those early days, I think, just to give some context, there was a lot of confusion, if I can say, about what we should be doing as a profession, with in terms of guidance, strategies, etc. Things hadn't filtered through centrally. We were waiting, I remember, and colleagues just waiting for that moment where we were all going to be called to some big meeting somehow and have this, briefing of, this is what we're facing, this is what we're going to do. That never really came. And again, not to put any blame whatsoever on my clinical leaders, I've now subsequently learned that they were also waiting for that big moment, that big central briefing. Okay, this is it, guys, this is what we're going to be doing. That didn't come for them. And what I've learned subsequently as well, and I have permission to say this from meetings that I've been having with other people in relation to future response and resilience, is that clinical leaders were phoning other colleagues in other hospitals to say, we know this is coming, we're watching the news, we're seeing what's happening in China, we can see it coming across Europe. What are you doing to get ready? So that was the environment that we were operating in.
So it's slightly informal, if you like, when actually what you really wanted was some direction from leadership. Is that really where?
Absolutely. And I was drawing on my own background in the military. I mean, that's whenever we deployed anywhere, there was a big movement of preparation and deployment and preparedness. But we didn't have any of that in this situation. And I think that was a bit of a shock for many of us. We had healthcare workers not even sure if they should take their leave, things like that in February time, or travel abroad on holiday. Should we go? Should we not? Don't know what to do. No one's telling us what to do. So that was the level of confusion that was going on at the time, sort of January, February time. And then again, I do want to talk a little bit about Heathrow. I was really shocked, if I may.
Well, I do,
but
right, okay.
I'd
like to try and just stick within the confines of the healthcare system.
Fine,
but of course, clearly some of those people went into quarantine.
Absolutely. So so I saw it from the perspective. So what happened at Heathrow and what happened on that day when I got that phone call kind of made me realise actually that the entire system is not ready.
Right.
So whether it's within my hospital in a small trust in North Wales or working within a wider healthcare system in London, in one of the busiest airports in the UK, but for a big entity like Public Health England, which was, designed to keep people safe. So in terms of the, very briefly, the Heathrow Airport scenario, I was really shocked how the week before I'd been there and the response was as I would expect it to be. If the crew from the aircraft calls to say, we've got someone, these are the symptoms, okay, what do we do? The action would be, keep the person on the plane, we will meet you at the plane, come up the steps in our PPE, and we'll take a history, take a name, decide on what the next action is, but hold the person there. We'll take their details, we'll log and track and, trace, if you like, tracking of that. The following week I went in, nothing had changed. The number in terms of the wider situation, the numbers were still going up. Within the country, the stats of people getting sick every day, we were hearing that it was getting higher. When I came into the shift that week with higher numbers, the advice was, we're not going out to meet any more planes. We're not even taking their names. Or this is all you have to do. You've just got to take the phone call from the flight, and then you've just got to tell the person to get home by. And my question was, well, do we need to know where they live? Do we need to know who they are? No, we don't need to know what their names are. We don't need to know where they live. We don't even need to get them home. Just you tell them to get home by whatever means. And I asked, do you mean even by public transport, on a bus, on a tube? Yeah, that's fine. Just tell them to get home. And that was February. So, and then at the same time in North Wales, when I was on shift.
Well, can I just stop you there, Dr. Ahsan?
Yeah.
Just
Sure.
pause for a moment. And it may be my fault for not making you slow down just so that we can keep up. It's all right. But really, essentially, what you're saying to us there is there was a shift within the week in your experience at Heathrow, which really goes back to preparedness, which something is Ladyship has already heard about and obviously looked at it in depth in Module 1. And so I just would want to sort of actually bring us back to what was going on, perhaps not at Heathrow, but in that smaller setting that you were coming on to telling us about.
Yeah.
And certainly then coming on to deal with your experiences when your father went into hospital. Can I just finish the passengers on the train account, please? When you sought advice as to what to tell them and where they should go, what advice were you given?
Okay, so when I phoned up, I remember getting the call. We were in the doctors and nurses sort of room where we make all decisions and have the board of all the patients, etc. And I remember speaking to my colleague saying, okay, well, what do we do about this? And I was the consultants had gone home for the evening, and I was the in charge registrar in the evening, and I spoke to the nurse in charge, and we pulled out a folder. The folder said, "Call this number." I called that number, and I think what we had were a few pages at that point of what to do if, and I found that there was. I can't remember if there was actually.
Let me help you.
Someone to call.
Yeah,
Was there someone?
Yeah, let me say you tried to call Public Health Wales. It was a Friday late at night, and in fact they'd gone home. You left a message, was told you'd get a call back the following week. Of course, the point being that the passengers by that time were already in Wales and absent the advice they were looking for.
So what I can't remember is if it was an automated phone call or whether there was a human being on at that Friday night, and I think it was an automated message. But I just remember that I was able to relay that I needed to pass on a message that someone's coming from, I think it might have been an out of hours individual person who basically relayed that you need to call back next week.
So another example there of preparedness or the lack thereof potentially. All right. Can I jump forward in time to December 2020?
Yeah.
And I think it's the case that on the 17th of December, your dad, who I think was 81, a retired teacher, had asthma and a number of other symptoms, but was generally well, had to go into A&E. And on the 17th of December, it's suspected that he caught COVID-19 in the hospital. And he was discharged, I think. Is that right?
Well, he went in for just a standard
procedure.
Something that I had done with him many times before. It was just about a catheter that was blocked, quite routine. And we believe, and this was during that period of time where I had wanted to get home to lock down, but I was on shift and I was working. But it was during that period we feel that he caught COVID during that period of time.
I think you said he was tested upon arrival, but the result was lost. And when they retested him a couple of days later, he received a positive test result and then was placed nonetheless on a normal ward initially. Was that whilst the lost test result? Right, understood.
So during that period of time, he'd gone on in for just a normal, rather routine thing, catheter change. He wasn't a normal. He didn't normally have a catheter. Something had happened during that period of time that he needed it, and it went in very, very quickly with one of my siblings. Came back home, but a few days later started to have signs and symptoms that made us worried, and we were, again, we knew that there would be waits, etc., and for him to be seen. Again, this was all second-hand relayed to me because I was on shift in North Wales, and it was a case of two of my siblings, both of them medical, just making the decision to take him into A&E, and it was a frightening journey because he was having difficulty in breathing, and they got him to A&E. A swab was taken at that point, but lost. A chest X-ray was done. It was quite typical of the COVID picture, and my siblings were there.
And I think were you able then in due course to take some compassionate leave from your job and come down to join him in the hospital?
I think,
I just want to ask you about that because you say he was moved to a COVID-19 ward. He needed one-to-one care, which you provided, and you stayed in his room for 24 hours a day for 6 days in full PPE. So clearly there were visiting allowed. Just tell us, what PPE were you wearing whilst you were with your father at his bedside?
So it was almost the same PPE as I'd been wearing in ITU in my hospital, bar the big, excuse me, I've forgotten the name of the big respirator that we wear. But I wore in the hospital with my father in the room it was a full gown,
Yep.
gloves, a fluid-resistant mask, not an FFP,
No,
but
one of the
other
one of the blue ones.
Yeah. But fluid-resistant, so
Yep.
3-ply, and a visor.
Right. And was that PPE that was provided to you?
Yes.
Yeah. All right. So you wore that throughout the time at your dad. Did you observe what the nurses and doctors were wearing? Were they wearing similar levels of PPE?
Yes.
And can you help at all with whether
I can't recall if it was an FFP3 or a surgical. I think it was a surgical mask. FFP3s, I think, were for when there was nebulized aerosol generating procedures.
We've heard about those. All right. And I think you say, though, that whilst your dad was in the COVID-19 ward, he was not taken to a high dependency unit, although you were told that would have been the right place for him. Were you told why it wasn't possible to admit your dad to an HDU?
Yeah. So, and this was happening again. It was really challenging because I just really, during that time, I really sort of wished I didn't know the details, that I didn't know what was happening. I just really wished for ignorance. Because I knew that I knew what we were doing in our hospital, where pressures, we were busy, and actually everything coincided at the same time. I was called, I got compassionate leave to come home for my father whilst things were getting busy in my own hospital. So it wasn't just an increase in cases in London, it was also simultaneously increasing in North Wales as well. And I felt, bizarrely, a normal reaction was feeling guilty leaving my colleagues, but my colleagues were incredible and gave me that time to be with my father. And so I went, I was with him, and I knew that, just even the week before, or even the weeks after when I went back to work, that there were patients who were similar to my father. If we had capacity, even the age and other comorbidities, they would be, they would get, if it was deemed correct for their care package, and in the patient's best interest, then, and there was capacity, then that's where they would be going, which is how we would normally function, where you have those important conversations with family members and the patient about ceilings of care. What we had on this occasion, and what I experienced with my father during that time in this particular hospital, which was under enormous pressure, and this is a hospital that I have worked in the past within the emergency department.
Just tell us, what did the consultant tell you about why your dad could or couldn't go into HDU?
So we waited all day. I remember it being a really, again, that's why I feel so much for family members on the issue of time, where the, time takes on a different meaning when you're just terrified for your loved one, and there's things are not moving in the way that they should be. And within healthcare, time is really critical, as we all know. I don't need to tell people that. But I remember those couple of days where everyone was just exhausted and working without breaks, working without. I couldn't recognise this hospital that I'd known and worked in for years before. Bearing in mind, my sister was also a GP in that hospital, running urgent care downstairs. None of us could recognise this place that we'd all grown up in clinically as doctors and worked in. It had just transformed, and the consultant that day, eventually she came to see me. She looked exhausted, really exhausted. And her registrar had come earlier in the day, and I could see the list of things that they had to do. It was huge. It went on for pages and pages, and they hadn't. The registrar had definitely not had a break. I could tell, and this was about 5 or 6 in the evening, and essentially, we just had a really sort of frank discussion with the consultant. And she said, look, you know, and I know that this isn't how it would normally be. I have got 40-year-old male patients that I am trying to desperately find an ITU bed for across the region. You know, that's what I'm dealing with. And at that point, I knew that this is it for my dad.
Was she basically saying to you that in normal times he might have been a candidate for HDU, but because of the pressures they were under region-wide, he was not going to be admitted into high dependency?
Yeah, he was not going to get that level escalation of care. He'd reached the ceiling of ward-based care. Right. The next step would have been one-to-one care. Yeah.
Now, can I ask you about care? Because clearly you were at his bedside for a number of days, and the hospital had a policy that if the patient had had a carer at home, they would allow the carer to remain in the hospital, and I think your dad had had some care at home. Are you able to tell us, Dr. Ahsan, what you think his care would have been like, or how it would have been impacted if you had not been present?
Yeah, that's frightening. It's really frightening. Because
why do you describe it in that way?
There were so many. He was in a side room, and we had to advocate hard for him to get into the COVID ward. I remember those few days of just frantic phone calls. Again, you just got the sense of the system being so overwhelmed. People were exhausted, running on empty, just overwhelmed by the numbers. And my father, before he went into the COVID ward, had been in a normal ward. Yeah, he was in a normal ward. But I think, to be honest, many other patients in this normal ward had respiratory symptoms as well. And we had to sort of advocate for him to go for them to repeat the test and to prove that he had COVID, but also look at the patient symptomatically. It looks like COVID, it must be COVID, and to move him onto the COVID ward, because then that kind of opened up another passage of care, including CPAP, which is the big mask that I think everyone's aware of, and the medications. And I think... I'm so sorry, could you just repeat that? No,
it's not at all. You described it as being truly frightening to have contemplated what care your father would have got had you not been there. And is really what you're saying to us is because they were so overrun that had you not been there, his care would have never to have been
I think
less.
It would have been, again, I think this is one of, we're now going into one of the areas where I have had a huge number of flashbacks. Because I remember...
Take your time.
And it's one of the contributing factors as to why I haven't yet gone back to work. But I just remember feeling so completely helpless. And, you know, from the perspective of someone the week before looking after other people's parents, fathers and mothers, and now really relying on others to look after mine. And just being super frightened. I just remember my sort of feeling like my legs were going to give way at some point and feeling so scared I felt sick. But like seeing, like my dad would sometimes slide down the bed, and the moment COVID is so positional, and the minute a patient moved, anything could just set them off and they'd be fighting for breath, in a way that you see horrendous, you know, on television, people suffocating for other reasons, you know, dramatised, you know, in films. Well, this was suddenly very real, and seeing a grown man thrashing on the bed to breathe was really harrowing. And bearing in mind that I'd actually been in ITU, and so we had intubated patients who were calm, and you know, that weren't in that. They might have been like that for a short while before we took over, and then and relieved those kind of symptoms. But with my father, because there was a ceiling of care made, he wasn't going to be for intubation. And we'd had those discussions, and I think I agreed with those discussions. We'd had those discussions earlier.
I'm going to ask you about that, if I may.
Yeah. So so for him, the ceiling of care was CPAP and ongoing treatment. But during that period of time, he would slide down the bed. Sometimes he would thrash. He'd be really, really frightened.
Yeah.
And he'd cry out. It was, I've never seen my father like that. And sometimes the piping from the CPAP would get dislodged. And, again, that was his source of oxygen. But if I hadn't been in the room, I don't know how the overworked nurses in that space would have been able to keep an eye on every single side room. Yeah. So I just kept thinking, thank God I'm here. What about the others? And I hope that by being there, it took some of the pressure off the nurses for the other patients. But again, I remember being in that side room and seeing the porters taking yet another trolley of another person out just across, behind us. Obviously, the nurses, we have a routine normally that when a patient dies, that curtains are drawn, every effort is made so that other patients don't see this, but there were too many.
Can I perhaps bring you to the end of your father's life? And you just touched on it, there were some discussions had. Was any DNA CPR discussion had with you or your siblings in relation to your dad? What was the communication like when those discussions were being had with you and your family?
I think we were, again, minded that was an important area for us and for my father. He at some point got so bad that he just said, I want to die. And to hear that, and he just said, I want to die. And at this point, his mouth was full of blood from, I don't know whether it was the pressure of the CPAP. He'd been on CPAP for a good few days, and he had not eaten. He had lost a lot of weight. His stomach was rumbling from hunger, but he was too scared to take the mask off, because every time we took the mask off to try to feed him, he would desaturate, become really frightened. Yeah. I remember I took him a favourite drink of his. I took it's a drink, a yogurt drink, and I thought he might like that. And I can remember his face lighting up when he saw that drink, and then when I went, shall I pour it? And then he said no, because he didn't want to take his mask off.
All right. Just pause there for a moment. All right, doctor. Obviously, you had to have painful discussions with the doctors and indeed your family about what may happen to him. And do I take it from everything that Matt Fowler has said in his statement that from the COVID bereaved family's perspective, it's the communication around the DNA CPRs that is the real concern? The way you communicate with the patient, the way you communicate with the family, how it's recorded. And we've heard a lot of evidence about potential failings in that regard, areas of good practice in that regard. So I won't need to trouble you with that, all right?
But what I have to say that I think we were fortunate. We were fortunate that we did have those conversations. Again, with DNA CPR, and I really feel for the families, because the end of a life happens once, and it has to be done properly, because the impact of when it's not done properly can last a lifetime for others. It's so important. And again, very, very quickly, I know the impact of it going wrong, because it happened to my mother in 2019. Horrendous death without adequate, and this was pre-COVID, without anyone really being sympathetic or giving us the time for end of life. And at that point, we were really desperate to have proper end of life care, and it didn't happen. We were really terrified. My father was terrified. Well, he had witnessed it, and we were terrified of him going through that same route. But on this occasion, we were very fortunate that the conversations were had, and they were had in a supportive way. And when my father had said, "I want to die," we were able to then move forward with the appropriate medication to help him to be more comfortable and to stop having those horrendous symptoms.
Two very contrasting experiences there.
And what I'm really sad and upset for the other members of the group that they didn't have that opportunity, and I fully feel their pain because we experienced what they're experienced with our mother.
Your dad sadly passed away on the 28th of December, is that right, of 2020, so just before the new year. All right. Can I ask a bit about your experiences? You've told us about the PPE that you wore as a visitor when you were caring for your dad. What about when you were actually working in Wales? What PPE were you provided with then?
When I was working in the emergency department, I remember it varied, it changed. I remember right at the beginning of the first wave, there was a period of time when guidance was coming out of how we need to respond. Eventually, guidance was coming centrally. When I say centrally, I suppose what I'm thinking about, the Department of Health, NHS England, etc. Eventually, it would arrive to us all the way in North Wales, and then we would be given guidance on what we had to wear. And it started, I remember one particular week, it was full PPE was the guidance if we come into contact with COVID, suspected COVID, and we were fit tested for this, which is, tested with the FFP3. And so we started the week thinking that that's what we're going to be wearing. During that same week, I believe it was about March time, it was downgraded almost on a daily basis 3 or 4 times that same week, to eventually the end of the week, it was literally just a normal surgical mask and an apron and gloves. And when you've got an informed, scientifically minded workforce that are asking why, is there new evidence? Has something emerged? And we would be pointed back to the guidelines, and they would say, well, the guidelines say, and then when you refer to the guidelines, and I was making another dispatches at the time, so we were looking at this evidence. There was no new evidence. They were still relying on the same scientific evidence, but just the guidelines had changed. And then... I just
want to clarify, when you were talking about the same week in March time, I assume we're talking about March 2020. All right.
Yeah, March 2020, and to the point, and I remember it so well. I remember that period because, I have now subsequently learned that was just unique to us in our hospital. That was happening everywhere, and I remember it. And if I may, I remember colleagues being really alarmed that one person even posted on a Facebook group that we'll be in flip-flops and Speedos by the end of the week. That's how bad it was, and people being generally concerned, but then with no real explanation. But then in different, again, it was where you were in different sections of the hospital. So if you were within the decontamination space of ED, which is where the really sick COVID patients who would need aerosol procedures or intubation would go, we would then wear full PPE. So it was FFP3 masks, visors, gowns, etc.
In your statement, you make reference to, whilst working, you saw and wore out-of-date PPE, including masks, during the second wave. And you say this, the face masks broke while wearing them. Is that a reference to FFP3? That is. I can see you nodding.
Yeah, I have photographs of them. They're on this phone, where you can see, which I'm more than happy to provide you, because I took photographs of them and I filmed them because I was as I mentioned, also filming at the time. But you could quite clearly see stickers that said a date in the future, and then when you looked underneath that sticker, there was another sticker that was an out-of-date sticker by at least 2 or 3 layers of different dates.
Were you ever told what tests had been conducted on the mask to make sure that they were safe?
No.
And I think you said it was the elastic breaking.
Yeah.
And indeed, you experienced that yourself.
Yeah,
whilst
I
you were
experienced
dealing
that. I remember speaking to another nurse who that had happened to as well within the decontamination space. And when you're in that space, there's a process to get in and out. It's not a normal room. There's an inner door, then there's the donning and doffing space, and then the outside bit. So and you would be in that room because there would be, a patient that was either going to be intubated or there'd be lots of viral load in that room. And when, the masks, the straps, I don't know if people have worn the FFP3 masks, they're quite thin, but, these ones were sort of out of date by at least 10 years, and they did snap, and it snapped on my face during a procedure. I just remember going sort of like this, trying to,
Just put your head on your shoulder to try and hold the mask on.
Yeah.
I follow you.
And I don't know what the nurse did, how she managed. I think because it happened to her on a separate occasion. But and again, I don't want to alarm anyone. You just kind of extract yourself as quickly as possible, and sort yourself out.
Can I ask you about some experiences that you had with COVID? I think you contracted COVID yourself, and you said you've subsequently developed symptoms that are being examined for long COVID. Have you actually had a diagnosis now of long COVID?
So I have a diagnosis of lupus.
Right.
I began to feel unwell I just thought it was burnout. I thought it was bereavement grief. I thought it was all of that. But I went to the GP, and I thought, well, it must be the time of life. And she said, no, let's just do some bloods. And a blood test came back as abnormal, that had been normal in earlier years. Then that just unlocked the door to other tests, and it turned out that I had developed lupus, and I've seen a few professors. I'm looked after quite well. I've been told a number of times it's quite unusual for someone your age to suddenly just develop lupus. So
had you had the lupus symptoms before you'd had COVID?
No. So there's obviously a trigger. The way that it was, described was that somehow the lupus has been unlocked. You might have had a dormant sort of tendency to have it, but something has come and unlocked. What has happened? Well, I've had COVID. And evidence within literature does suggest that there have been cases of lupus being developed as a consequence of COVID. But unfortunately, I'm not sure if it's come up already, but, in terms of long COVID and research into this area, there's not much funding, and funding is being shut down, and also funding for the care of people with things like this in this spectrum of area is being quietly ended. So, for example, in North East London Foundation Trust, they did have 4 COVID clinics. I think they've shut 3 down, and there's only 1 COVID clinics.
Can I ask you something, if you can, about a number of things that you've alluded to? In your statement, you set out the number of TV and radio documentaries that you have been involved in relation to COVID. And I just would like a sort of overview of what talking to other patients and staff has given you, as if your own personal experiences weren't enough. Can I just ask you this, Dr. Ahsan? In making the documentaries and the programmes, how many clinicians and patients have you spoken to?
I think
roughly.
in excess of 50 along a course of a year's worth of filmmaking, writing, print and radio broadcast, radio documentaries, a really large number of people.
Can I ask you about the patients firstly?
Yeah.
What were their main concerns or things they were raising you about the impact that COVID had on them and their experience of the healthcare system?
You had people who, again, I just remember quite clearly people who had other conditions who needed high-level care, critical care, but with other conditions, and the fear that they had of catching COVID, of delays of coming in. I remember speaking to one lady who had fractured her hip. That's something that we normally would see almost immediately as soon as a patient is scooped off the floor and brought in. This lady had stayed at home for 4 weeks with a broken neck of femur, with a neck of femur fracture. I've never heard of anything like that before. We had patients who were terrified of coming in. My brother, for example, immunocompromised patient, but himself a doctor, had caught COVID whilst working. And if I may quickly say, he was working within the first wave. Again, horrendously poor PPE, and he was actually working in the same hospital where my father had died later that year. He didn't have PPE. He was being sent to work in cubicles with patients with, as he described it, there's some really strange patients coming in right now with weird respiratory symptoms, and this was the wave 1. And he caught it. I was able to look after him during the first wave because I myself was terrified of him going in.
Dr. Ahsan, can I ask you, your brother's concerns about PPE, was that things you were hearing from the staff that you were working with on the documentaries and the TV programmes?
Yeah, I think there was there was fear about PPE, about the lack of PPE, about not being told the truth about why we're not having insufficient, levels of PPE, and why, again, a scientifically minded, informed population are being told things that just don't add up. And now we know the reasons that there wasn't enough. It wasn't the fact that it was safe. And I think, again, with healthcare workers and what they were telling me, there was, I think it was a lot of them, well, let's talk about the patients, concern about coming into hospitals, concern that what impact this was having on existing conditions. I interviewed a woman with cancer, the early stages of cancer diagnosis, and the absolute terror and fear that her and her family were going through on how they were going to navigate this she got her diagnosis around about the first wave. So that was quite an impactful interview, and just alerted, reminders of the fact that there's a whole, the rest of healthcare is not going to stop because of this.
If I can bring you back to the staff, I think you say in your statement you have 4 months of footage that details concerns, poor supplies, out-of-date PPE, which you yourself have experienced, and staff stress, which again you've very ably, if I may say, brought to life today, having watched what happened with your dad. Can I just finally ask you this, please, Doctor? I think you say that as a result of everything that you've been through, you've suffered depression, anxiety and burnout from about March 2021. And you had to take, I think, a break from your PhD, and it's impacted your ability to return to clinical practice. Have you been able to resume clinical practice? What's the update there?
I haven't yet, but I must. And it's about being able to go back into an environment where there'll be patients who are short of breath and being able to deal with that. I know that this has had a really detrimental impact on my career progression and my ambitions of what I want to achieve within emergency medicine. But I'm very fortunate that I have really generous and empathetic colleagues who have, but I think it's because we all know what we've each been through. I just want to sort of, and again, during that time that I was filming, I cannot stop, not mention the healthcare workers that didn't make it, our colleagues. That's up to 52, that's a doctor a year that didn't make it, that died from COVID. And there were a significant number of healthcare workers who were from the Black and Asian minority community, extra vulnerable. What might be helpful to know is that early on, not that early on, but I think it was around about June, July time, that we were all being screened. We got phone calls from our hospital if we were from a Black and Asian minority community, identified that we would be at higher risk, and we had a telephone call for screening. So that at that point meant that someone somewhere has recognised that we are extra vulnerable. But during the course of the media work that I was doing, I spoke to a surgeon, the family of a surgeon, Mr. Abdul Mahbub Chowdhury, who was a surgeon, a urology surgeon in the Homerton. I mean, we're talking about urology, we're talking about surgery. So just confining high-level PPE to certain professions wasn't correct. He had posted on Facebook an open letter to the Prime Minister asking for adequate PPE. He sadly caught COVID and died, and I had the privilege of speaking to his son and arranging him to tell his story on Channel 4 News. Really painful. We have the story of Dr. Yusuf Patel, who was an East End GP, much loved by his community. Again, we talked about GPs earlier, but again, healthcare workers, he was in his early 60s, very vulnerable as well, and trying their best to the end, and sort of dying in the line of service. And we had people from all ages. I think the youngest was that I've read about is a 44-year-old Dr. Seji Abdul Raza Seji, who was a GP trainee. We had surgeons, we had anaesthetists, we had so many healthcare workers and frontline staff succumbing to their illnesses. And I spoke to, in the course of my work, being trying to tell their stories, spoke to many of these people, and I think the data was one thing, but the real life stories and the accounts of what people experienced and saw and witnessed is really crucial. It's so crucial. And that's one of the reasons why I try to make, content, try to do two jobs at the same time, because something didn't feel right, that we were being told these numbers that were going the wrong way on an almost daily basis, wrong way, i.e. going up. But we were still having alternative narratives coming out right from, the Prime Minister himself, from the Secretary of State for Health at that time, from other people associated with that department that were downplaying or giving alternative narratives to what we were actually physically witnessing. And if I may talk about just one very quick example, as I say, things didn't make sense with what we were seeing on the ground, with what our patients were telling us and what they were witnessing and experiencing. I tried to understand how there could be such a disconnect. Okay for the first wave, but definitely for the second wave, what was going on. And this was a year later, I had an opportunity to speak to a civil servant. It was at a social gathering, so I wasn't prepared. I didn't realise that she would be there. It was a social gathering, And obviously the subject of COVID came up, as it often does, and people wanted to ask about what I'd done during it, and I told them it, and it turns out that this individual was a former advisor to Matt Hancock, and she, at that point, stated that everyone was on the front, well, she was on the front line, her front line was just as hard, and so it was very combative and defensive, and that her experience was just as challenging and as hard as a frontline healthcare worker dealing with patients who couldn't breathe and were thrashing on the bed. And that gave me an insight into the absolute disconnect between the people that were actually making the decisions were not connected with the people that were actually delivering the care. And there was a massive gulf. I would still like to have...
Can I just pause you there? Because as you were giving that answer, Her Ladyship was nodding when you said the data is one thing, but it's not everything. And we've heard a number of pieces of evidence to that effect. And so can I just ask you this finally, please? I suspect the lesson learned is to try and bridge that gap between what was going on the front line and what the decision makers were being told or the data was telling them. Is there any way, Dr. Ahsan, that you think that gap could be bridged and that practically we could do different in the event of a future pandemic?
I think there are a couple of things. I think understanding that data are not each specific number is a human life, and a human life that has gone on a journey. And when you're thinking about the data that relates to COVID, that's a death that has not been an easy death. The illness is not an easy illness. And at that point in time where the system was under so much pressure, that it would not have been an easy journey. It would have been a frightening journey for all involved. I think resources and fund, I have to bring it back to funding, but, you know, the Health Foundation states, you know, even with an extra 38 billion a year by the end of next Parliament, so that's 38 billion a year, will allow the NHS in England to meet growing demands. And where we are, you will know the graphs better than me and you'll have pored over them. But right now, in terms of the EU14, we are so low down on that scale. We are number 10 out of the 14. And there is no... When you talk about the pressures that we faced, and I know that there was extra funding ploughed in to the NHS during COVID, but then you're asking for ready-made things to be able to be brought off the shelf. Well, you can't just buy a ready-made, highly experienced consultant or a nurse to suddenly buy them off the shelf. These are not sort of pre-packed things that you can just suddenly build overnight. This takes money, time and investment, and resources as well that take many years to build up. Training, for example, takes years to build up. So it does boil down, without any shadow of a doubt, and through the NHS that I started in and to the NHS that began to emerge from 2010 onwards, it was very different.
And I'm going to stop you there, if I may, Dr. Ahsan. That's all the questions that I have for you. Thank you very much. My lady, is there anything that you would wish to ask Dr. Ahsan?
No, thank you very much indeed, Dr. Ahsan. I'm extremely grateful, obviously, for the work you did on the front line, the work you've done trying to bring to the attention of the public. You shouldn't really need it, but I'm afraid people are beginning to forget all that you're trying to do to bring matters of concern to the public attention. And I do hope that you haven't suffered too much distress from helping us today. I appreciate that some of the things you've been talking about may have been triggering. I know you're a doctor, but don't forget to look after yourself and get support if you need it. And I'm really grateful to you for all the help you've given us.
Thank you.
Thank you, my lady.
Thank you. Very well, I shall return at 2:05.